We're about that time. Good afternoon, everybody. I want to welcome everybody to the 2013 Advanced Health Plans Users Group meeting. We really appreciate everybody taking the time out of their busy schedules to come down and talk about arguably a very important subject, but definitely not the most exciting or thrilling subject. But we're going to hopefully make this worth your time, not only in understanding more about what we are trying to do with your health plan, but I know that most of y'all are also very concerned and interested about the Affordable Care Act and how it may impact your health plan, and we're going to talk a little bit about that as well. But I want to kind of do some introductions here first. I'm Jay Kempton. I think I know most of you all. We also have Maria Robles Myers is the Advanced Health Plans in-house attorney. That she's going to actually be speaking a little bit later here in the conversation about the Affordable Care Act. I also want to introduce some of the trustees. These are your elected representatives on the health plan board, and I'll kind of start over here on the far left with Robert Jennings from Chakota and Kirk Pittman from Sealing. Next to him is Roy Nelson, which is actually the chair of the health plan this year. Dr. Keith Smith is not a trustee, but you all have met Dr. Smith last year. He's going to be kind of a guest speaker here. We also have A.B. Bayouth from Exchange Bank and Skytook, and last but not least, Lynn Kinder from Payne County Bank in Perkins. I think we're missing two. We're missing Jeff Nunn. He's one of our Texas trustees that he lives in Amarillo, so we'll kind of give him a pass. And then also John Scheller, I think he had a prior commitment. But we want to thank everybody for coming on in. You all have a packet in front of you all that is really going to cover everything that I'm going to have. Every slide that I have, you have, and you all actually have more than I have that we'll just reference instead of going through several pages of reports and stuff like that. We'll just let you all take that home, but I'll try to reference things, but you can definitely follow along with what we're going to be talking about. Really the topic as far as the health plan update, this is a very much a good news message today. I want it to be very congratulatory because you all have done a whale of a job. We've been doing this, I think this is our 4th or 5th year of having these user group meetings. And this is the first one where I think there is actually a truly demonstrable positive outlook, which is, healthcare. There's not a whole lot to be positive and optimistic about, but there definitely is with this meeting. Good news, consumerism, free market principles, some new programs to help keep our momentum strong, ACA update, and then questions or your trustees. We also have the board made the decision, I guess about a year ago, or maybe it was this spring, I lose count, actually has a new role. We actually have the concept of an advisory trustee. So you'll see there that a couple of the past chair and two past chairs, Paul Freeman and Guy Sims, are in an advisory capacity for the health plan. Raise your hand there, Guy and Paul. Back here behind a pillar. We went through those. We also, I think we have a few ex-trustees that have been here. I want to recognize real quick Robin Batson from Broken Bow. She's all the way up that's about as far southeast Oklahoma you can get, still be in Oklahoma. And Bruce Benbrook is here from Stock Exchange in Woodward. Okay, so last year, for those of y'all that were here, we asked you to take ownership of your plan, start treating your plan as an owner as opposed to a customer or just a user, and you did. And that's this is kind of part of that payoff. And a year ago when we kind of introduced some of these concepts and everything, we didn't know how successful it would be. We've had a tremendous amount of reach out from my staff, but more importantly, a tremendous amount of reach out and resources that have been expended by you all, the bankers. Allowing Advantage staff to come in and meet with your employees and talk about some of the cost containment features that are out there. And you all are really starting to look at it as this is not just some insurance gimmick out there, that these are actually tools that are, have been brought to you. You all are paying for the tools. It's coming out of your plan assets. And so if you don't use them and we don't get the benefit, it's just another drain on the plan. And you all have really, really stepped up, and it is very much a collaborative effort, and your hard work is definitely paying off. Some of the metrics that we want to talk about, obviously premier provider utilization is huge. That's something we're going to talk a little bit more about. Our term is advantage premier providers. It's actually kind of a movement, though, that is starting to sweep our state and also our country. It's being driven by the self-insured employer. This is not something that is coming from the insurance industry or necessarily the big healthcare industry. It's coming really from a grassroots perspective. It's coming from, again, that self-insured employer that is, where there is no insurance layer. It is simply paying employees' health claims out of their plan assets. Those are the folks that are driving kind of the revolution. But premier provider utilization so far, as of I think it was a month ago when we put these numbers together, we'd had 237 procedures were done at an advantage premier provider. And folks, just so y'all know, in November it will be 2 years. So that's pretty impressive. Lots of folks have made the decision to utilize a premier provider. We actually have an accounting just for everybody to look at. It's right behind the Premier Provider, Advanced Premier Provider tab, and its report looks like this. It's got a green stripe at the top. I'm not going to go through all these. You can look at those on your own time, but that's where we get the $2.4 million in savings. And those are hard savings. That's not any of the soft, well, we prevented a claim that maybe was going to happen and didn't. This is actually seeing, okay, this is what we've historically paid for certain procedures, and this is what we've paid for now with these 237 instances. Folks, that $2.4 million, that drops right to the bottom line of the health plan to help offset future rate increases. The thing that's so amazing about that number is we were able to do that. You all were able to do that by not, in the game that is the health insurance game, if you want to see savings always come from what? I'm either changing health plans, I'm raising deductibles, or I'm raising my employees' out-of-pocket costs. That's where savings traditionally come from. The bank may say, well, I've saved, $80,000 a year for this. Well, a lot of times they've passed that. Those savings really didn't materialize organically. They just came out of the employees. In this situation, that $2.4 million was done by actually enhancing the benefit to the employee, which has been, it's a huge blessing. It's a incredible thing that you all have been able to achieve simply by making better, smarter healthcare buying decisions. Your employees out of pocket has been less, and the plan has saved $2.4 million. Prescriptions. We had a slight change in the contract with the pharmacy benefit manager. That was done a year or so ago. But I credit the $372,000 reduction in prescription claim utilization also to the efforts of David Weaver and Vicki Toombs and all the HR people and management of the banks that have allowed us to come in and talk about generic drug utilization, talk about therapeutic substitutions, being able to, again, buy better. If we've got drugs out there that are just as effective, but there's one that's a lot less money, you all have been kind of figuring out that, hey, we can maintain quality but save a tremendous amount of money, and that's what's happened. And I want to add on that $372,000, folks, prescription utilization and prescription inflation, it has been as high or higher than medical utilization. So the fact that number is negative at all is So in other words, the ultimate savings are a lot larger than just the $372. One call, that's the imaging, which is essentially kind of like a premier provider arrangement for imaging. $289,000 worth of savings there, 229 scans. We are also building, as you all probably have already gathered, we're starting to do some arrangements with some premier providers that do MRI scans. And so, I think nobody tell one call, but I'd like to see us at some point where we're able to buy better for MRIs and CAT scans and PET scans and things like that without having to go through an outfit like one call. A good example would be if Dr. Smith owned an MRI machine and we worked with him to get a better deal, and we went through one call, which is almost like a PPO, like a negotiator. It's taken us a long time to figure out that if we just walk in and talk to him directly, he can make a little bit more money, and we can save a little bit more money simply because we're cutting a layer out of the transaction. Does that make sense? So we're even though one call's done a good job for us, there's a way to do a better job, and we're working on that. Lab card, you all have utilized Lab card 1,187 times, which is wonderful. Lab card, we're all. There's no spin here or anything, so we'll just tell Lab card. We've had ups and downs with Lab card. I've kind of lost count at the number of mergers and buyouts and renames and everything else that those folks have gone through. But they still do provide some good pricing, and you all are still utilizing that program, and so it is reaping. We are seeing benefits. Healthcare Blue Book, something that we just did. I think it was January of this year. We've had over 7,000 searches by Advantage Health Plans participants for Healthcare Blue Book. Now, those are savings that are harder to quantify because that is, just simply somebody is buying better. So if they use a more efficient provider, a green provider, if you will, in Healthcare Blue Book, to us, it just looks like a claim. It's just a lower dollar claim. So that's good. But the fact that there are 7,000 searches, there's utilization out there. So again, I commend you all on that. Back to, one of our favorite subjects. Everybody can hear me okay? Okay. PPO discounts. The PPOs are becoming more and more laughable, more and more obsolete every year. And we had some examples last year. We have some new examples this year. These are actual claims. Had a bilateral knee replacement. The build charges from the provider were just around $200,000. The network discounted it down to just under $150,000. If that participant had that done, and I believe that bilateral knee over at McBride, their premier provider price is, I think it's $29,000. When you say that, you're thinking, my gosh, I talk to employees out there. I've talked to a lot of them and said, well, some of you, your coworkers, well, do I get anesthesia with that if I go and get that done? It's got to be apples and oranges here. It can't be the same deal. But as you all know, McBride is a top flight facility. Recently was named one of the top orthopedic centers in the country by Consumer Reports, #1 in Oklahoma. And so you have the quality, and also that apples and oranges thing. If you see one of our graphics that we're going to be taking to some trade shows this year, I thought our graphics guys did a great job, and that is, just when you think you're getting an apple, it actually is maybe an orange. But we're helping people look at the way they buy healthcare differently. Spinal fusion, same thing. Hysterectomy, fibular fracture. We actually have a better example of a hysterectomy that was done here recently. It didn't make it into the slide. But it curls my hair. It was done in Durant at the Durant Hospital, and the build charges for a hysterectomy, it was a routine laparoscopic robotic hysterectomy. Build charge was $69,000. The PPO discounted it down to $52,000. If we had that done at Surgery Center of Oklahoma through some of their facilities using the same Da Vinci robot, Dr. Shambor would be the one that would do that. The premier provider price for that was $13,000. Same technology, top flight surgeon. So again, and I kind of belabor this a little bit, is that if you do have any employees that are, even though we've had a tremendous amount of utilization, I wanted this to be super positive, and it is, but we've also had a tremendous amount of still missed opportunities where, folks would go somewhere and would have the opportunity to go somewhere else. And sometimes the excuse that you hear or the reason is sometimes they're very good reasons. Sometimes you just, face palm. It's, well, I've already met my deductible, or I've already met my out-of-pocket max, and it's already free, so I'll just go wherever I want. And those are missed opportunities. In some situations, the cost of getting it done at a premier provider, it can be 70-80% difference. We have new premier providers, and I'm sure that you all probably see more than you'd like. Our Did You Know updates, probably the best way to kind of keep up to date with this fast-moving train that is some of our initiatives is by reading those Did You Know articles. But some of our new facilities, probably since the last time we spoke, definitely Oklahoma Surgical Hospital in Tulsa, probably Breast Imaging of Oklahoma. I think they're new. Comprehensive Diagnostic Imaging, Digestive Disease Management. I think those are all new facilities. The ones that are in red were actually named by Consumer Reports, and I'm sure Dr. Smith will explain why his facility is not highlighted. He's got a good reason for that, which you all will understand. The coming soon is, multi-specialty group here in Oklahoma City is coming soon. Neuroscience specialists, Foundation Surgical. Those are all three that I don't really have an update on how imminent they are, but they have indicated a desire, and they're working on getting their pricing together, getting it bundled into something that's rational, and not getting it where it's not all component in components. But we also have a lot of Texas premier providers that are looking to come on probably within the next 30 days. So it'll be good news for our Texas banks. We've actually had a lot of utilization from Texas members that have come to Oklahoma. It's surprised the heck out of us. It really has. But I think we said last year, the Texas banks are, I don't know what you call it, less generous or what, but the deductibles that the bankers in Texas are a lot higher than what we buy in Oklahoma. Some of them, we've got one group that has a $5,000 deductible through Advantage, and they do not couple it with a health savings account or an HRA. Those employees really feel a $5,000 deductible, and we routinely see those folks. They actually are in an ad for the IBAT, Independent Bankers Association of Texas magazine. There's actually an ad that's featuring this bank because I think they've had 3 premier providers, and they're about 6 hours away from Oklahoma City. Pretty impressive. Keep the momentum strong. That's really the message here, folks. We've got great results here. Hopefully one of the trustees will pipe up, and because I pledge that I will not take personally questions about rate adjustments or anything like that. The trustees, that's their forte. I don't get a vote on the board, so we can talk about that. But the idea is keeping the momentum going, keep doing what we're doing, keep educating our employees. If they push back, making them understand that, hey, the money that's spent out of this health plan is the same money that is used to pay your raises, bonuses, buy new equipment, expand the bank, etc. Some of the things, though, that we're doing to keep that momentum strong are the Go Green to Get Green initiative. That is part of Healthcare Blue Book. Does everybody remember that? We rolled that out July 1. I don't have any metrics on it yet because they only tally that up and pay rewards. Healthcare Blue Book only pays rewards once a quarter. So we'll get some reporting out to you all on how many employees have actually earned a reward. But does everybody kind of know what that, if you use Healthcare Blue Book for one of those procedures that are over there in that box on the right, colonoscopy, upper GI endoscopy, sleep study, cataract, Doppler exam of the heart echo, heart perfusion imaging. The reason those procedures are up there and not more procedures is those are the procedures that we do not have premier providers that do, but there's the most amount of price variability within PPO networks for those procedures. I don't have the pricing, what's rational on those, but there's so much variability that if we could have an employee utilize Healthcare Blue Book, a lot of these are diagnostic, so it's not like somebody's got some disease state that's ongoing or it's an emergency or anything. But there's a tremendous amount of cost variability. If they buy better, we'll actually pay them a cash reward which they can use. It's not plan assets, so meaning that they don't necessarily have to use the reward just for healthcare related things. They don't have to pay their copay or their deductible with it. This is purely, this is just a cash reward. They can do anything. They can buy pet food, gasoline, car payment, whatever they want. Does anybody have any questions about Go Green to Get Green or Healthcare Blue Book?
I do.
Yes.
Do you have, like you said on diagnostics, you get colonoscopy as an example. People get those when they turn 50.
Right.
They don't really know who to call, and they don't necessarily want to call 25 doctors. Hey, what do you charge? You don't have a list or something? Maybe in Oklahoma City area.
Healthcare Blue Book is really that list.
It gives doctors.
It gives if you like, digestive disease is one that comes up, and they're getting ready to be a premier provider, but they're not effective yet. But right now, today, if you would go to Healthcare Blue Book, digestive disease specialist would be one of the green providers, say in the Oklahoma City area. Now, if you click on digestive disease, you actually just click, there's a hot link there. If you click there, it will show you the physicians that work at, same way with McBride or Oklahoma Heart or Surgery Center of Oklahoma. You click on their name, it'll show you all the physicians that work there. And of course, this is something that's a great point. Thank you for bringing this up. It reminds me to tell you all that your plan, Advantage Health Plans Trust, we actually do, we meaning you do pay for a service that Healthcare Blue Book provides called Price Finder. And there's a 1-800 number on the Healthcare Blue, right when you log into Healthcare Blue Book, it's down there in the lower right. There's a benefit summary that says what deductible you have and everything else. Down at the bottom of that list is a phone number to access Price Finder, and that's going to be a human being that's going to assist you all with finding that facility or that provider, that doctor that utilizes digestive disease. It's in your Healthcare Blue Book manual. And of course, the easiest Price Finder would just be calling the Kempton Group, and we can definitely refer you to the Healthcare Blue Book folks to do that price finding activity. Yeah, okay.
Jake, do you know change parameters on that Healthcare Blue Book where the rule banks? Because I think it only was like 25-mile radius.
Yeah. We've been working with Healthcare Blue Book kind of on an ongoing basis to Healthcare Blue Book. I think they're out of Nashville, Tennessee, and back east. So they kind of think big city. And the idea that you would need a search radius more than 20 miles just kind of blows their mind. And so like, folks, we may need to push that out to like 150 to 200 miles to get any representation based on where some of us work. So we're working on that, guy. It's been kind of a challenge, and it's a very local type of deal. So if anybody has at their bank, they put in their zip code, which is what the system will pull, and it's not giving you any search results. You can always change the zip code to, if you live in Colgate, but you normally would orient towards Oklahoma City or to Dallas or McAllister. You can grab a Dallas, McAllister, Oklahoma City zip code, put it in there, and it'll search within that radius. But again, this has been kind of an interesting conversation that we've had ongoing with Healthcare Blue Book, and they've been a good partner to work with. But when we try to explain to them that, well, they live here, but they really buy healthcare here, which is 98 miles away, they don't know how to deal with us. But anyway, we're working on that. Any other questions on Healthcare Blue Book right now?
For everybody.
Thank you, AB.
There is a little app you can put on your smartphone, and you can find the colonoscopy. You have 4 green providers, and all right there.
There is an app for that. Works for Android too. It's free. Put in your there's a little bit of login information, so it's not generic. It's actually to you, so it knows that you're Advantage Health Plans, and it knows who you are in the app. But that is designed that if you're in the car or you drove to Tulsa and you don't know where you should go, you don't have your computer handy, you do have hopefully have your smartphone. Yeah, Megan.
The code for the app is AHPT.
Okay.
Ask for a plan code, it's AHPT.
Advantage Health Plans Trust, AHPT, is the plan code for the application for Healthcare Blue Book. Thank you, Megan. Also, last thing is on the Go Green to Get Green. Down there, the last two items there are no forms for the employee to submit to get their reward. They just go to that doc, and if that doctor is a green provider or a provider that charges at or below the fair price, they will automatically be entered into getting that reward. Again, Healthcare Blue Book accumulates that and cuts checks once a quarter for that. So once we get some of that, we'll kind of monitor how that's working and everything. But there's nothing the employee has to do. And also Premier Providers, this was something else that we customized with Healthcare Blue Book, is we wanted to make sure no matter where you were, if you were in South Texas or you were in the Oklahoma Panhandle or wherever, we wanted to make sure that the Premier Provider pricing, which we know what it is to the penny, that it is automatically going to come up in any Healthcare Blue Book search. And that's really provides you all a reference. And it also looks, we want you all to kind of think of that as a known good offer. And of course, the Premier Providers would love it if you would just come see them. But they're always going to show up.
Jane, you might mention also as far as the pricing, whether it's used or not, it costs the plan. So the more usages that it gets. That's right. That's a good point. Down.
Yeah, Healthcare Blue Book is a subscription that your health plan does pay for. So it's your it's like when I said at the beginning, it's your tool. So the more we use it, the more it's able to pay for itself. If we don't use it, it's just another drag on the plan. Okay, just a quick little case study. We thought this was really cool. We thought it was so cool that ABC News also agreed, and they did a write-up on this. You can read it. The link to the full story is there, ABC News. You can just go to abcnews.com, and I think you can just probably type in Oklahoma Surgical Center. But this was a gentleman named Ira Horner, lives in Woodward. He needed to have knee surgery for a torn meniscus. And he had that scheduled at not a Premier Provider. He had it scheduled at another orthopedic surgery center here in Oklahoma City that has not embraced transparency, kind of the same, nothing bad about them necessarily, but they are not into this movement. And so Ira went in there and learned, the kind of the normal drill that we've probably all gone through once or twice in our life. And as well, we're going to work with you to determine your financial responsibility, Ira. And here's what we think we're going to charge. And you need to meet $750 of your deductible. And here's what your 20% is going to be. That ended up being a fairly big number for Mr. Horner. And he remembered that at his employer, there was some crazy Kempton person that had been in there talking to him about this transparency. All he knew enough to call our 1-800 number. And we said, Ira, we can see you're pre-certified for that torn meniscus repair right where you were already planning to go. And yep, you're going to be out that deductible and that co-insurance, but thank you for calling. But, you've got some other offers that are known good offers that, your employer's health plan the offers are so good and the quality is so good that they're going to pay for it 100%. And well, my gosh, I guess I'm going to go ahead and do that. And he had kind of made the decision, I'm thinking probably going to Surgery Center of Oklahoma. His doctor kind of threw a fit. Just could not get his head wrapped around why a patient would care about what something costs. Just why would you even look at this through an economic lens? I'm your doctor. Well, but can you tell me what it's going to cost if I get it done at your facility? Well, no, but I think we've already worked with you to determine what your deductible is going to be. He said, no. I want to know what it really is going to cost because my employer is self-insured. That dialogue kind of went on, and basically at the end of the day, Ira was willing to vote with his feet and said, well, that's great, but if you won't give me a price that is comparable to my standing offers that I have at these other providers, I'm going to go to one of them, and my employer is going to make it free for me. The facility relented, and they matched the price that was offered by Surgery Center of Oklahoma. So, I mean, that's what we're talking about here, folks. I told you all last year, this is not another network. This is the anti-network, and this is about employee empowerment. Giving Ira the option of being able to negotiate with some leverage as an individual. He was free to choose his other. If he bought over here, he was going to be out as a deductible and out of pocket. If he bought over here, and he said, I want to use you, but you're going to have to come and play. You're going to have to be in the ballpark. And we did, and paid it at 100%. He did not have to change his physician or his facility. It was a great story. Again, ABC News picked it up as well and thought, how can this be? Well, how can it be? Who's bought a car in this room? I mean, that's what we do every time we buy a new car, right? By golly, I'm going to walk out of this dealership if you don't. I got 3 other deals. I mean, as Americans, we're great at that. We're experts at that, and Mr. Horner applied that to healthcare and won. Really, I'm pretty much done, if you can believe that. But Dr. Smith, we were going to ask him to just say a few words kind of about how this movement is going and what he's been up to. And then after that, I think we'll have Maria up to talk to you all a little bit about Affordable Care Act. So, Dr. Smith, it is yours.
Good afternoon. I think I won't talk very long, and I'll answer more questions than I'll spend time speaking. But I wanted to talk about what's old news with this movement, what's current, and what's coming. I'm always trying to think about what's the next thing, and there's plenty of people all over the United States that are trying to copy what we're doing, so I've got to stay ahead of them, and so I'll kind of clue you into what we're thinking about. It's almost as radical as what we've done so far. I'm thrilled to be here. Jay's leap of faith to deal with, and the trustees' leap of faith to deal with us on this basis, and that's what it was ultimately, was really a huge thing for our surgery center and for this movement, and you deserve as much credit as anybody for making this happen. Walt Duncan actually may have lit the fuse 2 years ago, I believe, at this. Or no, it was you. Okay.
It was a team.
We had put our prices online over 4 years ago, and I was beating my head against the wall because nobody seemed to notice except the Canadians. The Canadians, they were the first patients to show up because they could buy their way out of the long lines that they're in. And then you all came to this meeting a couple of years ago, and Walt knew what I was up to, so that sort of got things started. 9 months ago, 2% of our business at the surgery center was through our internet portal, and I include all self-funded business, people with high deductible insurance, HSAs, people with no insurance. My favorite, people who have insurance, but for whom their out-of-pocket expense is more if they use it than if they come pay our internet price. That's now 19% of our business. So in 9 months, what we've taken on through this internet portal is up 10 times and shows no signs of weakening. In fact, we're becoming concerned that capacity is going to be an issue at some point. I cannot wait until that's a problem. Somebody asked me the other day, what is your capacity? And I said, well, any room that has a Blue Cross patient in it represents capacity. So that's my answer to that. We've lowered many of the prices that we've listed online. Some of them have stayed the same. I'm going to begin to change some of the prices to get rid of the variability so that implants are included. We're beginning to see some patterns where the actual implant charges for various surgeries are very, very tight. And I, of course, make fun of the surgeons that are just use a lot of implants. So they're, it's becoming more predictable. So some of the price disclaimers on the website, I think, are going to go away. And we lateral the implants that we use that cost. There's no markup on that. But I think I'm going to, if you see.
And I've got to jump in right there. That is a monumental, earth-shaking thing. I just about had to pick myself off the floor when Keith told me that 2 years ago about implantables. I mean, hopefully none of you all know. And we really look hard at implantable devices because it's not uncommon for us to see markups in the 1,000% range. And I'm talking about stents, and I'm talking about screws and rods and pacemakers and spinal orthopedic implants. And so when Dr. Smith said, hey, well, we don't really bring any value, we don't add any value to implantables, so why don't we just send you what we paid for it, and you just pay our cost? Honestly, I thought, oh my gosh, in my day, I couldn't believe I was speechless. And so, that is a huge, huge deal. And for the most part, our other premier providers are looking at it that same way. We buy, as Dr. Smith said, hey, I buy this thing out of the back of a guy's trunk. He brings it over and unloads it and brings it in. We sterilize it and we put it in people. How much money do I need to make on something like that? So, had to interject.
That's fine. Yeah,
Something? I have to hold this button. No, I don't. The other end of that is, I can tell you, I've been, I wouldn't say embroiled, but let's just say an ongoing discussion with legal counsel for a PPO. And their position basically is, you're required to pay what we bill minus the percentage. You can't ask for an invoice. You're not entitled to know what it costs. And so you see this extreme and you're looking at it and you're going, wait a minute, that doesn't make sense. It's so surreal, but it's still an ongoing thing.
And that decision on our part is an extension of our philosophy. We entertain no arrangement that's not mutually beneficial, none, even with our vendors. So I don't understand. We don't have implants even in inventory. They're on consignment. So I don't have opportunity costs lost or anything. The rep literally brings in a tray and he has all the implants and we decide the ones we want, and then I get a bill for those 30 days later or 60 days later. So we don't really add any value by just opening these things up in the operating room. So it doesn't make any sense to mark them up. And so it's just an extension of our decision to be always act in a mutually beneficial way with everybody. One interesting thing is that the vendors now that have these implants will come to me and say, now, is this a cash pay case? Is this one of those Kempton players? And I say, why? And they say, well, we have some samples that we can just give you. And so you never see those.
Wow.
And so the vendors are beating each other up, trying to be, preferred vendors with us. And the more samples they bring, the more I prefer them, it seems. That's an interesting development. It doesn't happen every case, but it seems like it's more frequent. Currently, I'm scouring the website regularly looking for ways to make the prices even more transparent, in some cases actually lower many of the prices. We have competitors that are emerging. There will be prices, I think, that people will see that are very close to ours. But it's not all about the price. Our whole mission when we started the surgery center, it was a quality mission. And our goal was to be the value. And it just so happened we were the best surgical care in town for the lowest price, which makes us very difficult to compete with. And that was our goal. And we wanted to crush anyone that wanted to compete with us, but we found there wasn't any competition. And There's a part of my makeup that makes me crave that. So as competitors emerge, I welcome that. We may respond with some pricing. In all likelihood, we'll respond by making the value greater and the benefit greater. But it's beginning. This is a movement. This price transparency movement is something that will not be stopped. And these legislators, in a very silly way, or many of them are considering mandating transparency. And all, as I was told somebody on the radio yesterday, all that does is provide an opportunity for a politician to sell exemptions. I mean, because the government in healthcare is a mess. I mean, it's just corrupt. And you get a politician involved and they mandate transparency. I mean, that's the chance to sell. And then the hospitals can claim they're transparent and probably not be transparent. So that's how I see. I told the guy that the only thing that could possibly derail the transparency movement in the United States is if the government supports it. They always screw things up. They always mess it up. But I think that nothing is more vicious in its discipline than the free market. And the facilities that don't embrace price transparency, they will perish. And I think it's too late. I think the cat's out of the bag. We will be in the Wall Street Journal tomorrow. We've been in the New York Times, ABC, MSN, CNBC. I was on the Stossel show. If y'all haven't seen that, that was kind of a fun interview. That, by the way, was uncut. If you've seen the Stossel interview, that's exactly what it was. It was uncut. It was funny because we were sitting there and the guy was doing this, the countdown. And when we got to 2, Stossel looked at me and said, keep your answer short. We have a lot of ground to cover. And they had submitted this list of questions that they were going to go over. And the first question was not any on my list. And so I hesitated and I thought, well, okay, I can do this. But it was what you saw was exactly uncut what happened. Allie Meyer got word about us through Channel 4, through the weather chaser Mark Dillard. I was asked to be on the Neil Cavuto show and was sitting in the studio and they were counting down and we got to 7, 6, 5, and then they said, the story's canceled, the Benghazi thing broke. And that happens. I mean, in the media, they're just like that. I mean, it's just, you never know. So Dillard said, well, they want you to wait for 30 minutes. So I said, oh, okay. So we sat there and I visited with Mark Dillard for 30 minutes and he said, this is the second time you've been at this studio. Let me ask you about your facility. So we had this 30-minute conversation and he said, this is a great story. He said, we have got to talk to patients. We've got to talk about this. So Allie Meyer got involved. And show that video here in a minute. Oh, are you okay? And what I didn't know had happened is Channel 4 had sold, and now they have this parent company, and they send it to every affiliate in the United States. So it was on countless NBC stations in countless places. I mean, almost everybody in the United States that had access to NBC that saw this story. And that's when the New York Times hit, and it's been quite a ride. I did a 30-minute interview with Ron Paul that will be viewable tomorrow. They're going to release that tomorrow, and that's very interesting. And he's somebody I think a lot of, and I was just very, very honored to be interviewed by him. That's sort of the media craze, and in the meantime, we see more and more beneficiaries of AHP coming to the surgery center. We see other third-party administrators other than the Kempton Group being leaned on by the employers who they represent, wanting to know, why are you not funneling all of our people to these places like Surgery Center of Oklahoma? It's been really interesting. It's been really, and I've learned a lot. I still don't speak the language, but I'm learning. What's coming, I'm really excited about. Has everybody in here seen the actual website at our surgery center? Are y'all familiar with that? Is there a way we can put that up?
Yeah. I think it should be live here, so I'll pop it up real quick.
The only reason I'll show it is because it's fairly new. We just launched this in April.
There it is.
Here we go. Our original website was state of the art when we did it a little over 4 years ago. This one, I've had techies call me from all over the United States who don't know anything about healthcare, who said this is the coolest website we've ever seen. But the thing that really makes it stand out is this. You can point to the nose and press on the nose, and there are the nose procedures. You can point to the hand, you can point to the ankle, you can point to the neck or the spine, and then you come over here and there they are. Anterior cervical discectomy with fusion, one level, 16.5. I've seen, and you all have too, I've seen $175,000 bills for that. So our new website has got there's a link to my blog and all the media. I'm putting media on here as fast as I can, and I'm a little behind. There's a lot more to come, but there's the Reason TV, Stossel, Capital Account. This is an interview, one in the middle with a Canadian that was a real disaster. We didn't do her surgery, but I helped her get it. A couple of things I did on Capitol Hill. There's more of that coming. There's testimony in Congress that's coming up. Jules Madrigal is someone we have to get you in contact with. You did?
I will be.
Okay. There's a family practice guy in Austin, Texas named Todd Crump who just released his web pricing for primary care. And it's unbelievable. I mean, you cannot operate one of these federally mandated community clinics for what this guy has online. It's really, really a real value. Jules Madrigal she's been in the Wall Street Journal, and she's also transparent in her pricing in primary care. There's Huffington Post. I made them laugh at the end. They didn't see that coming. CNBC. We have our first patient from Hong Kong coming next week. Lou Rockwell. If you're not familiar with the Lou Rockwell website, that's worth checking out. He is, I think, the most provocative and insightful writer.
Can you believe that this guy is a physician? He sounds like, he's an entrepreneur. There's the thing that's different. This is what you get when healthcare opens their eyes and say, we want to compete for patients, honestly, openly, on our prices and our quality. They just start thinking like you all, and we do. And it's really cool.
And we want to be part of the solution, not part of the problem. And I told somebody yesterday that there's actually an added level of accountability for a Kempton beneficiary or an AHP beneficiary that comes in as opposed to any other patient, because all of your eyes are on what we're doing too for the benefit of that patient, not just price-wise, but quality-wise. So there's actually an additional level of accountability on us for the experiences that the patients have that come through you all trusting us. So that it's all good for everyone. This is the idiot Craig Jones, that's the Ali Meyer story. He and I go way back. And then this guy, Dr. Jeffrey Singer, was in the New York Times. He was the guy that they interviewed for the story about the patient that paid $3,000 for their hernia that was quoted $27,000. So if he used his insurance, it was going to be $27,000, and if he didn't, it was going to be $3,000. That's this guy. And so he's on Fox and Friends and starts talking about the Surgery Center of Oklahoma and our pricing. And there are more. I'm real behind. I haven't been able to put them all on here. What's coming that I'm really excited about is we are going to expand. We're going to build out 2 of our additional operating rooms so that no matter what you or anybody else throws at us, we can handle it. The other expansion is that I've successfully reached out to 2 physicians that are not in Oklahoma City, who are in Norman. One's a urologist and one's a gynecologist, because we have so many patients coming from Ardmore and Gainesville and Dallas and from south, that it just made sense to me that if they could see someone further south, it was more convenient for them, then that surgeon come to our place to do the procedure. All the savings are there, but the convenience there is there for the patient, because talking to a general surgeon in Lawton, who I know very well, and I don't know if I think it's going to work, but for people in Wichita Falls, Vernon, Altus, that area, they could easily, if they needed a hernia or gallbladder, I would let him operate on me. So they could go see him, have everything arranged, and then he would come up to Oklahoma City, and we'd try to, if it worked out, we'd see if we could get, 2 or maybe 3 patients, scheduled on the same day. He could do their surgery, and then they would never have to come back to Oklahoma City. They could just follow up with him in Lawton. I'm also going to Tulsa. And this is probably going to draw more fire than anything we've done so far, because these surgeons are actually going to leave Tulsa and come to Oklahoma City and operate, and then go back, and the patients are going to follow up with them. So I don't know. It will be limited only by the availability of people that I know who are qualified to do these surgeries. I mean, otherwise it won't happen. But there are enough good people out there. I think that's something that we're going to try to do for the convenience of the patients with no quality sacrificed whatsoever. So that's bold, but that's coming. The other thing that we plan to implement in the next 6 months are telemedicine capabilities, so that the surgeons can actually interact with the patients prior to their making a trip. So, show me your hand, show me your CAT scan of your sinuses, show me your shoulder, how much mobility do you have, that sort of thing, so that there can actually be kind of a hands-off physical exam in addition to just a phone consultation prior to the patient traveling. That's what we're working on right now, and there's a video that's coming to our website that we think will help patients realize more where they're going and what they're going to see when they get there, and that's probably a week away. That's really going to be cool, and Allie Meyer's actually doing the voiceover on the video. So that's kind of where we've been and what's going on now and what's coming, and I thought that was probably a good way to kind of bring you up to date. And I can't thank you all enough for your trust. We're honored to take care of all of the employees that you all send us, and I hopefully we're without a complaint yet. Thank you very much. What do you want to do?
If anybody's got questions for Dr. Smith, let's go ahead and take that time, and we'll turn him loose.
Yes,
Yes.
Dr. Smith.
I'm in no hurry, so.
Are there any plans, or has been dialogue? I'm from Tulsa, so you maybe either do a co-partnership with some of the private hospitals that have excess capacity, or joint ventures, or even mergers, I guess.
As long as people are willing to travel to see us, it doesn't make much sense for us to recreate the wheel. And to be perfectly honest, the nuts and bolts of why patients get such great care at our facility is the people. And it's taken us 16 years to gather this crowd of nurses and scrub techs and ancillary personnel. And there's a culture that just can't be, it can be duplicated, but not very easily, and certainly not overnight. So as long as people are willing to travel and drive an hour and a half, I think it probably makes more sense at this point for us to say, we know what we do well, and we're going to stick with it, rather than dilute it or water it down in any way. That I think you will see. We feel like we've embraced this model because it's the right thing. We think people now will do it because it's kind of a gun to their head, and they're going to kind of have to do it, or they're going to watch all these cars flying down I-44 towards Oklahoma City. But I think others will do it, and they're going to have to. I think it's unstoppable now.
Oklahoma Surgical Hospital in Tulsa they are a premier provider, but I think they're a good partner, and I don't want to throw them under the bus, but they're kind of dipping their toe into the pool. I think Dr. Smith is right. They weren't doing it necessarily because they are just out there. They're not out loud and proud, like others, but they're doing it kind of as to stop they can see that this is coming. Quick Trip is embracing this. Alliance Coal. I mean, the big Tulsa employers are all about this movement. And I think Oklahoma Surgical Hospital in Tulsa was just the first to say, we better get in front of this thing before we get run over by it.
What about the doctors themselves? You're bringing on some other doctors, but what about the culture of the doctors themselves? Because that drives the bus as the surgeon. You've seen doctors and surgeons asking for transparency or talking about that more, or what do you hear on the doctor side?
Well, our model has changed. This has changed our model at the surgery center because when we started, the surgeons, they would just bring their patients to us by virtue of us saying, here's what we do and here's how much it is, and alliances with Jay and others. The surgery center is actually the source of the patient referrals. So one of the things that I decided to do early on in our payment structure, our prices are very low, but a big chunk of that goes to the surgeon. He's paid better for these procedures than any other business that he has. And that's why when I call and I say, Carlin Yates, who's the Thunder basketball, he's the doctor, and I called him and I said, got a guy with a rotator cuff injury. He said, we'll tell him I'll see him later this afternoon. I mean, that's what happens, and that's why. And he's a stud. He's a great surgeon, and he will see them that day, and he'll bump somebody to get them in. So the surgeons I work with, they wish it was all Advantage health plans. I mean, they wish that's all they had. Interestingly, the other physicians I talk to in other parts of the country, they want this so bad, but they're scared. And doctors are not very good with risk. I mean, and that's a benefit for patients. I mean, we're supposed to be risk averse with patients, but physicians tend to translate that same mentality into their practice and their business. And that's
another issue that you're dealing with in a lot of areas is, the surgeons, they don't have a say because they're not autonomous any longer. They're employees and they do what their employer tells them to do. Right. The physicians that have autonomy, the surgeons that have autonomy, they're the ones that are. I think you're a better crystal ball reader in this, but the surgeons that are still autonomous are the ones that are really the ones that feel like they have the ability to thrive and not be an employee of the hospital are embracing this. I think as Obamacare kicks in more and more and you're seeing less and less reimbursement that's actually going to the surgeons that work for the big health systems, you are going to see more and more fallout of the really high quality physicians and surgeons that are going to fall out of the system, if you will. And once they see that there is a marketplace that is available to them that doesn't have cost controls and everything else, and not a lot of those dollars are being sucked up by a facility. As Dr. Smith has explained and some of the other premier providers, you've got, and it's rare, but I've learned a lot that in a facility such as Surgery Center of Oklahoma, the facility is just seen like a tool. It's just like a scalpel or some other piece of machinery. It's just a tool to help the surgeons do their job as quickly and as efficiently as they possibly can. That is not the model for large hospitals. The facility is where the profit center is. That's who needs to make the money, and the surgeons and the doctors are just simply a cog in the wheel. Over at a surgery center, like Dr. Smith said, the surgeon is the one that, again, makes the most money, and the surgery and the facility is run as lean as it can.
I tell people we can probably claim not-for-profit status more legitimately than these silly hospitals that do it. We have two we actually have 2 surgeons that are hospital employees that work at our place. And when the hospital employment contract came to them, there was a specific clause in it that said you may not do cases at the Surgery Center of Oklahoma under any circumstances. And they just marked it out and said, you still want me to sign it? So 2 guys like that. Okay, thank you all very much.
All right, we are getting, I think we've got a break coming up here. Yeah, we're going to show you 2 quick videos, and then we're going to take a break. Are you dying, Robin?
I just had surgery at the North Texas Surgical Center, who is a possible provider.
Yes.
And your staff did try to talk me into use a premier provider. I have been with that doctor for 40 years, my family's done it. I am just this past week starting to get the paperwork, and as we all know, I was the oblivious, guilty. I'm not even sitting here past
You're in
this
good
thing.
company.
But, just said, call my insurance company, I had to get it done, blah, 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 blah. Starting to get the paperwork, nobody ever told me what it was. I'm sure that if I had used a provider, it would have been a fourth of what it's gonna be. I'm embarrassed. It was hard to leave a doctor I've used a long time. So that was my one concern, but
You could do
anyway,
what
I was
Ira
telling
did.
my husband, I could just kill myself for not waiting.
You could have done what Ira did, though. Said, hey,
I didn't even
let's
have
talk.
time or even consider negotiating. The poor doctor, he doesn't even know what it costs.
I know that, and that's the reality.
He showed up and did the surgery. He knows nothing. It's one of the North Texas Surgical Center. I think all the doctors own the surgical center.
Yeah.
It's one of those deals, so they funnel you through. My prescriptions were already ready for me downstairs.
Right.
Might go pick them up, not hand me something, just the
I mean, those are all good stories, as long as the price is part of the conversation.
They'll price it right after the fact.
Right.
If you make them and tell them on this one, I need you to back, they'll do it.
You think?
I will go back to that doctor and describe some of this, and that you're on the list, and doctor, if you ever want me to come back, I
Give
need
us-
you to do this. I've been with this clinic literally for 40 years since I was a child.
Robin, we'll get some information from you, because I don't want to ruin your day or anything, but I'd like to see what kind of a missed opportunity that we're looking at. And then we'll see where we want to take it from there. But
Stars are fresh, oh my God.
2 quick videos, and then we'll take our break. We actually have a star here in our midst. Lisa Gilmartin, you want to raise your hand? Oh, come on. She's over here. She is actually a participant over at Exchange Bank at Skytook, and she we just, we talked to you all, and we just kind of picked her as somebody that, boy, she really gets it. And she's really been embracing kind of this movement, and she's also been dealing with some of the realities of talking to your doctor about something that they don't want you to talk about, and are many times ill-equipped to talk about. But we interviewed Lisa for this we have I don't know if you all know, but Advantage Health Plans has a YouTube channel. I barely know we have a YouTube channel, but we do. And this is out there, but since we had everybody in the room, we would like to go ahead and just show it real quick. And this might be a good tool. This was done not necessarily just to embarrass Lisa, but also to be used as a tool for your employees, just from a fellow banker and how they've kind of approached this.
I went to the doctor, made the appointment, and had the exam, and got completely checked out, and then come to that point in the visit where they sit down and they go, okay, well, this is what I think. So he's talking to me about the results and what he thinks that I need to do, and he wants to send me for a test and some blood work. And I thought, well, okay, that's fine. And I started thinking, blood work, okay, I know I have a benefit for that, and I'm not sure what test he's going to send me for, but I think I need to check on that. And he started to write my chart, and he said, well, I'm going to send you here. And I had to stop him and say, wait a minute, I need to check with my insurance first. And he said, well, it shouldn't matter where you go because, you know, it's still going to cost you the same. You'll have a copay. Of course, I knew better. So first I stopped and said, okay, our plan is self-funded. And I don't think he understood what I was trying to say. And I said, it's our money. So we're trying to be more conscious of what things cost. So I just had to say, okay, this is what I need to do. I need you to write the orders, whatever you need me to do. If you want me to go have a test done, if you want me to have lab work, and then let me go and find out a couple of places that I can go, that I want to go to, and come back and you tell me which one to go to. And I really realized that, you know, I have some control. I can help manage the cost of our premiums. The healthcare blue book that's on the website, it's easy to get to, and it's easy to maneuver in. And then if you have any problems with it, it's easy to call in and get some guidance with it too. I knew that I could go and check different places and what they charge and get a fair price for that before I scheduled anything. So I didn't want him to schedule it. I wanted to check it first and then schedule it so that I knew I would be paying the least amount and still getting a good service. I would be paying the least amount and the plan would be paying the least amount.
She did a great job, didn't she? And like I said, hopefully that would be something that would be helpful to use. This is one, and a lot of you all may have already seen it, but this is Channel 4 here in Oklahoma City, the NBC affiliate. And they did, as Dr. Smith had said, they did this story on July the 8th. And we actually had some of these claims that they're going to be talking about actually came from Advantage Health Plans. And she's out also is filming a follow-on to this piece right here. She's already been out and talked with us. I don't know, Keith, if she's talked to you about the follow-on piece yet, but I think some of the other news issues have kind of put it back. But we'll play this real quick and then we'll take a break.
Well, listen to this. According to Time magazine, Americans spent a whopping $2.8 trillion on health care in 2012. Even for families with insurance, medical care is expensive. Well, tonight, a special report about an Oklahoma surgery center that is revolutionizing the price of surgery around the world and has some folks shopping for the best deal.
We are all familiar with the concept of a free market. You know the price, you make an informed choice. There's nothing secret about the price of gas or bread or milk.
Milk's fair, very fair.
In almost every case, you know what you'll pay before you buy.
What about medical expenses? Any idea what a hysterectomy costs?
No, but I'm sure it's outrageous.
Any idea what it costs to get a broken arm repaired?
Very expensive.
Any idea what the price of a hysterectomy costs?
Oh, no.
Any idea what the cost to fix a broken leg would be?
No, I really don't.
That's the problem with healthcare, according to doctors Keith Smith and Stephen Lantier. They launched Surgery Center of Oklahoma 15 years ago, founded on this simple principle: price honesty.
What we've discovered is that healthcare really doesn't cost that much, but what people are being charged for it is another matter altogether.
And so Surgery Center of Oklahoma started posting their prices online, all of them. Pick your surgery, see the price. They are all-inclusive, quotes, no $5 Band-Aids here, and they are guaranteed.
So when we first started, we thought we were about half the price of the hospitals. And then we find out we're less than half price. And then we find out we're a sixth to an eighth of what their prices are. And we're just shaking our heads going, I can't believe the average person in the United States can afford health care at these prices.
Our goal really is to start a price war.
And it's working. Their first out-of-town patients came from Canada. Soon, everyday Americans caught on. 22-year-old Matthew Gang tore his patella tendon, dislocating his kneecap playing basketball. He's from California. We talked with his dad, Tom Gang, on Skype.
He had no insurance whatsoever. He also had a part-time job, so he didn't qualify for the state insurance plan, Medi-Cal here in California, or the county plan here that we live in.
Surgery in California was going to be about $30,000. Here, less than $6,000, 1/5 the price. So Tom and Matthew flew from California to Oklahoma.
It was well worth it. I need a rotator cuff surgery right now, and I'm thinking about flying out there and having them do my rotator cuff surgery because it was such a positive experience for us.
A handful of other Oklahoma medical facilities have started joining Surgery Center of Oklahoma in price transparency.
And here we've said, in a very radical and unique way, we've said, here is what we do, and here's how much it costs.
Critics are quick to point out Surgery Center of Oklahoma does not take Medicaid or Medicare. They do take private insurance, though. Hospital administrators accuse the Surgery Center of cherry-picking the healthiest and wealthiest patients, those who can pay.
Where we can reveal information that's meaningful to the patient, we very much support that. That's what hospitals need to do.
Craig Jones is the president of the Oklahoma Hospital Association, which supports transparency, in theory, though Jones calls the issue complicated and does not expect major metro hospitals to offer online price menus in the future.
The difficulty when you compare hospitals with surgery centers, for instance, is that surgery centers have, most of the work that they do are elective procedures, and they're a bit more predictable in the sense of what it is that they're going to do.
Still, the difference in price is staggering. We obtained these bills from major metro medical centers. A breast biopsy at Surgery Center of Oklahoma is $3,500. At Mercy Hospital, they charged $16,000. Gallbladder removal at Surgery Center, $5,800. At OU Medical Center, they billed $21,500. A hysterectomy at Surgery Center of Oklahoma, $8,000. At Integris Baptist, that same surgery is more than $37,000.
I think there's a tendency to oversimplify the issue of price comparison. But I think there's no doubt that hospitals are and need to be more accountable to the public to try to make the services and the businesses that they carry out more understandable.
According to the Hospital Association, about half of Oklahoma's hospitals are losing money. But prices these days may be dropping because of Surgery Center of Oklahoma, as patients are demanding price matching. Some hospitals relent.
Hospitals are having to match our pricing because patients are printing their pricing and holding that in one hand and holding a plane ticket to Oklahoma City in the other hand and asking that hospital to step up.
The economics are not as simple as a loaf of bread or a gallon of gasoline, but perhaps not too complicated for patients who are finding ways to save on medical care. Allie Meyer, News Channel 4.
All right, Allie, thanks. Now, we contacted OU Medical Center, Mercy Hospital, and Integris Health for a comment. We received a lengthy statement from Integris, and in part, it reads like this. Instead of offering a generic price list for medical procedures, we work individually with patients to determine their financial responsibility. If you'd like to read their entire statement, we've posted it on KFOR.com.
All right, we have a break. I don't think the bar cart is open yet. That's too bad because we're going to talk Affordable Health Care Act after this.
Before I start, I want to make sure that I mention Surgery Center of Oklahoma, Keith Smith's facility, Dr. Smith's facility is not on that consumer reports. And the reason that it's not on the Consumer Report listing is because Consumer Reports does its ranking based solely on Medicare patients. and Surgery Center of Oklahoma does not do Medicare patients. And they rank them based on the rates of complications, the infection rates, the readmittance, and those negative factors in terms of rating them from top to bottom. So he doesn't get considered because he doesn't do, they don't have his data.
However, their infection rate in 2012 was 0.0.
All right. So we're going to talk about the other part of this. I'm going to divide this in 3 areas, and then I'm going to give you my insights. As I'm hearing people talk, it just kind of goes, the light goes on in my head. I still want to call it PPACA. I'm just not willing to go with the ACA. To me, it's PPACA. So when I say PPACA, it's the same thing as the ACA. 2014, it's supposed to be rolling out. I am anxiously looking for information to understand what it is, and I can tell you I'm a pretty diligent researcher, and I'm having a heck of a time finding what I'm looking for. For purposes of Advantage, there were a couple of changes that took place July 1. Advantage is a fiscal year trust. Even though it measures calendar year deductibles, it is a fiscal year trust. And so we have the applicable dates, not January 1, but July 1. So on July 1, there were a couple things that changed, mostly in the preventive services and women's services. The big one, and the ones that generated the most attention, no cost sharing. I don't call it free. I think it's no cost sharing because it is not free, but there's no cost sharing for preventive services. For women, it's the prescription drugs, the birth control medications that really have lit up a lot of attention because there is no copay on prescription drugs for generic drugs. They still have the ability to get the regular brand drug, or they can get it if the generic is not available, but generally it's no cost sharing when they do the generic. And then the one that most of the men in the room are just going to go, she's got to be kidding, she's going to talk about this. No cost sharing on a manual breast pump. Preventive services are really promoting breastfeeding and lactation, and so plans are required to provide assistance with that. Therefore, the plan does provide a no cost sharing manual pump, but the trustees voted an additional benefit into the plan, and you've seen the write-ups on this. For a person or a woman who wants something that is more than the single manual pump, their plan benefit does allow up to $200 on other versions, but it is not part of the no cost sharing preventive. It's just an additional side benefit. And that's probably more than you want to know about women. What we know. I almost am tempted to tell you very little. The mandate, there's a lot of confusion going on. PPACA, was intended to go into full effect during 2014. For plans that are fiscal year plans, it's the first day of their plan year, not January 1. Most plans tend to be calendar year plans, and so people always talk about it as January 1, but it's the first day of the plan year. It is the part of PPACA that is being implemented is the part that actually is supposed to favor the participants and the individuals. So far, we've seen a lot of stuff that's come into play with some additional benefits being mandated, but the real meat to it, the no pre-existing condition limitations, the full access, you got to get coverage, your employer has to offer you coverage. All that stuff is really a 2014. So what do I know? I know that the employer mandate, which is the pay or play penalty, has been delayed until 2015. That's the part of the statute that says if you're an employer that has 50 or more full-time employees or full-time employees and full-time equivalents, if the number's over 50, then you are required to offer coverage that is of a certain level and that is affordable, meaning that it has a minimum value, which is about 60%. And that it's affordable at the individual level, meaning that you can't charge more than 9.5% of the taxable compensation that your employee has from you, and it's a safe harbor based on that employee's income from you only, and their 9.5% of taxable compensation from you for single coverage only. So if Yes. Well, for us, it'll be July of 2015, right? So what Congress did, not Congress, I take that back, what the president did through the IRS in a tweet, believe it or not, it came out in a tweet over the 4th of July weekend, was to delay the application of the penalties on employers, which means that you're not penalized. It's that $3,000 or $2,000 penalty. Do you know what I'm talking about? Okay. That those penalties are not going to be applied next year. And the reporting that goes along to tell the government what you're providing in coverage to your employees and whether they're offered the right level of coverage, that is not going into play until the following year. The actual mandate is delayed for a year. So for fiscal year plans, it technically should be July 1 for Advantage Health plans. The reporting requirement that is delayed really is a calendar year plan because the reporting goes on W-2s, and you don't do W-2s on a fiscal year basis. You only do them on a calendar year basis. So there's kind of a disconnect in terms of what's happening there. The exchanges are supposed to open, but the income verification rules to determine how much of a subsidy a person gets are not in place. The computer systems are not in place to be able to generate the data so that they can determine that someone who signs up for coverage on the exchange actually qualifies. And if you can kind of think back when this stuff originally came out, individuals who are between the 100 and 400% of the poverty level are going to be offered a reduction in the premium cost and a subsidy to offset deductibles and out-of-pockets. So if you have an individual that is within those parameters, they are, in essence, going to have subsidized health care. Well, the mechanism to determine whether or not they qualify is not in place. So we're on a good faith basis. And I think, to me, that's probably one of those things that is not being talked about very much, and I think it's going to be the biggest surprise to people, because what happens on this subsidy thing is the subsidy is based on the calendar year. So when the IRS, you get an individual who goes to the exchange next January, they sign up, they tell the carrier that their income level is between the parameters that are reimbursing them that'll allow them to get a rebate or a subsidy. So they get a subsidy all year long, they file their tax returns, and now we're going to do the comparison to see whether they really qualify. So it's based on current year's tax, not prior year's tax. So the current year's income is what's going to determine whether they're between the 100 and the 400. And the reporting for 2014 is going to be in the W-2s that are issued January of 2015 and the tax returns that are filed during early 15 for 2014. And at that point, it's going to be kind of a surprise to some people. They didn't qualify. They owe some money back. People aren't talking about this. Maximum out-of-pocket limits on exchange plans are delayed until 2015. PACA is going to curtail how much you can have out-of-pocket costs, and what they're trying to do is synchronize so that the total between all of the out-of-pockets that an individual has are included in the one number. Well, a lot of plans have prescriptions that are done through pharmacy programs, and then they have the medical that's done through something else, and there's no connect between the two out-of-pocket amounts right now. And so what they've done is they've said, we won't apply that rule in 2014. We'll give you another year to figure out how to link them up so you can figure out what the real out-of-pocket cost is. The personal mandate is not delayed. That's the part that says if the individual does not have coverage during 2014, if they do not have coverage during 2014, then, as our president says, they're not paying their fair share, and so they're going to have a personal mandate. The personal mandate is really a nominal amount. I've read it different ways. It's $95 per person. I think it caps out at $200-something for a family of four, and they're saying that it's the lower of 1% of their income, taxable adjusted gross income on your tax return, or this number. The beauty of it is there's no collection mechanism. You can't, the IRS has no ability to go collect the money. They can't assess, they can't levy, they can't have interest charges, they can't attach your accounts, they can't write you nasty letters, they can't do anything other than offset the amount if you are owed a refund. And that's just the statute. That's the way they wrote it. So That part is not delayed. I think it's going to be interesting to see how that plays out because there's a lot of tension in Congress. The House has passed a bill to delay the individual mandate on the premise that they also passed a bill to delay the employer mandate. And their version is if you're going to delay the employer, then you ought to delay the individual. Both of them theoretically will go to the Senate. The president has said that he will veto both of them. It's unlikely that they'll get through the Senate. So it's just going to be one of those things that's delayed by executive order, not by change of statute. Minimum value plan. We've talked about this before. It is going to come to play. I've been kind of wavering with it, trying to decide whether to wait until we really know what's going on or just get it done. A minimum value plan is going to be an alternative. It's going to be an additional plan that's going to be offered through Advantage that is going to have a reduced level of benefits. I'm guessing it'll probably be a 60-40 plan. It's not a pretty plan. It's not really an attractive plan. It's not really a plan that's great for employees. But it is a plan that's going to meet the 60% minimum value. And our goal is to hopefully be able to price it at a level that an employer can offer it to their employees so that they comply with the pay or play mandate and not be subject to a penalty because an employee goes on the exchange. So I think we will roll that out. I'm going to tell you a little bit about the exchanges here in a minute, and I'll tell you what my hang-up is. Exchange notice, it's driving me nuts. Everybody's calling like, when are we going to get the exchange notice? I'm the cause. I've held it up. And my purpose is that exchange notice has to go out by October 1 of 2013. Every employer is going to have to provide this notice to their employees to tell them that there is an exchange and that they may be able to get on the exchange. My problem is I don't know what it is. And I'm like, why am I going to give people a notice about a non-existent thing? The exchange is supposed to be the federally run exchange in Oklahoma starting January 1. As of today, I can tell you that I have not been able to find out where it is, what it is, how it's going to work, who's offering coverage on it, and definitely not what it's going to cost.
What phone number to put on the exchange notice to contact the exchange?
It's kind of nutty.
Basic things like that.
The notice was supposed to go out in April 1, I think, or March 1, and they delayed it because they didn't have much on the exchanges. Now they're really coming up against the tail end of this deal because October 1 is when the exchanges open up for enrollment. So the exchange notices will be going out, and the obligation employers have is you've got to provide that notice to all of your existing employers by October 1 and to new employees who come on board after that when they're hired.
Is this all banks or ones with 50?
Everybody. Everybody. And it's really a nonsensical notice. It's telling employees that the exchange exists, that they have the right to enroll in it, but that they might not get subsidies if their employer offers them a plan that meets the stuff that would satisfy the mandate.
Exchange notice is everyone, Robin. Pay or play is 50 or
50,
over.
yeah. But the notice is for everybody. So you will be seeing them in the next, I think you're going to see them next week. I just struggle putting that together because it makes no sense to me. What we don't know. Maybe I should say what I don't know.
Question, does that go to just full-time? What about part-time?
I think you're supposed to provide it to everybody. And you just tell them the eligibility is, it says what the eligibility is on it, so they will know they're not eligible. In theory, it's what they're going to take to the exchanges to show that they're not eligible on an employer plan, for instance, because they might be a 20-hour person, or that they don't have coverage. For employers that don't have coverage, there is a notice that says we offer no coverage. That's not the one you're going to see. You'll see the one that says we offer coverage. I don't know how they're going to play out, to be honest with you. I'm still kind of, I guess, cynical in a way. If the open enrollment period starts October 1, there's so little information out about this. It's really hard to put your hands on it to understand what it is so that you can answer questions semi-intelligently. So they're not up yet. They will be up. It will be a federally facilitated exchange in Oklahoma. I know in Oklahoma the state got a special waiver that came out last week, I believe, on Insure Oklahoma, which was supposed to die unless they got federal approval, and they've got approval to allow Insure Oklahoma to remain, but only for individuals that are below the 100%. If they're between the 100 and 400% of the poverty level, they're going to be required to go on the exchange. Will they be viable? I'm withholding a conclusion. I don't know how much we're going to really have on them. You know, as I was listening to the transparency discussion, it occurred to me that the one thing that is really, really clear to me when I look at all of this stuff on the exchanges, because I have seen some of it, especially on the ones that are state-sponsored, like California has big marketing thing. Their website's really big and they show you. But it's real interesting to see what they put out there in terms of information. And it basically is this. You see a grid, and you say, if you're 25 and you get a bronze plans, it costs you, they give you the bracket of the poverty level, it costs you, and they give you a number, and the subsidy is the next number. So they don't even tell the person the total cost of coverage is $100. They just say, it's going to cost you $5. And then you read through their stuff, and there's about out-of-pocket, maximum out-of-pocket amount, and that's it. What it costs you to pay for the premium and what your out-of-pocket is. And as I sat here and I listened to the transparency stuff, I thought, that is so anti-transparent because it is the same game. What does it cost you? Well, whatever it is that truly comes out of your pocket, and you don't have to worry about the cost of health care. And that, I think, is going to be the way that the exchanges are marketed. I personally am a little bit shocked that I haven't seen more of it yet. I thought we'd get a little bit of a marketing blitz. The media has been kind of sidetracked maybe on stuff that's going on with Syria, and so they're not even talking healthcare right now. There's very little, but there will be a marketing blitz. There were 3 entities in the state of Oklahoma that got grants that were intended to be used to train individuals to be navigators and help individuals sign up on the exchange and teach them how to sign up and what they have to fill in. They're community organizations for the most part, and they got their approval August 15th, and the exchanges are open for enrollment October 1, and I'm sitting here going, who's training who, and what is it that they're training on? It's kind of scary. I keep hoping, there's an optimistic part of me, I keep hoping that I'm going to wake up in the morning and the news is going to say, exchanges have been delayed until 2015. And I'm going to go, oh my gosh, I don't think that's going to happen. Politically, that's not a very savvy thing to do. It just doesn't go with the grain in terms of what PPACA is supposed to offer. The contracts with the carriers that are actually going to be on the exchange are not yet signed. Federal government anticipates signing them the middle of September, they say. So there's some talk about who has applied, but what the carriers have, there's 4 that have applied, but you don't know which one's been approved because you don't know what the pricing is as to whether it meets the requirements for their pricing. And what has happened is the carriers have filed their applications with their information as being confidential and trademark pricing information, and so none of it is being released until the contracts are out. So I think we won't know what any of the prices are going to be until October 1. There is some news coming out depending on which ones you look. Some states are coming out awful. New Mexico, the analysis in New Mexico is that it's like, I forget, it's 120% or 70 something. It was this huge number that I think it was 100-something percent, 130% higher than what they currently had. And that shouldn't be shocking. In reality, it shouldn't be shocking because what's going to be offered on the exchanges are individual policies only. They are not doing group plans. There's no small employer group plans. They're only individual policies. Individual policies have not had to comply with the same parameters of coverage that the group health plans have. So, for example, individual policies have never had to have mental parity. Group health plans have offered mental parity for a number of years. So the mandated aspects of PPACA into the individual policy market is to expand the scope of services that has historically been offered. And you're already seeing the commentary kind of like that says, well, you can't compare the price pre-PPACA, post-PPACA. It's like apples and oranges because we got 2 different deals going on. I think carriers are being a little bit hesitant. They really don't know what the additional cost is going to be. I still believe that the exchanges will be an adverse selection. And by that I mean that individuals who truly need coverage, who don't have access to it elsewhere, will go on the exchanges because they need the coverage. Individuals that believe that they are healthy enough that don't need to buy it or that have access to cheaper health care are not going to go on the exchanges. It will be interesting.
I was just going to say, what we're seeing from many of our employers, and definitely the larger employers, is that the way that they're looking at the exchange, and I actually sat through an HR meeting at quite a large employer here in Oklahoma yesterday, and their comments to their HR directors were, our company, we offer, if one of our employees is on our group health plan, they're not eligible for the exchange. And so if they go out and get exchange coverage, it's immaterial to us. And that's really kind of our goal approaching this with our bankers. And that is, if you all remember, we've requested information, kind of getting nosy, I understand, but requesting information, how do you all share the cost with your employees? We've sent out those surveys, and that's really what we're trying to do. So we want to see how many of our banks out there are, do we think that they're going to meet the affordability standard? And then the other thing is that we've already had all of the AHP plans evaluated or graded, if you will, to determine whether or not they meet the minimum actuarial value for benefit richness, and all of them do. In fact, we have some of them that are in the 90th percentile, and the mandate is only going to have to offer it to the 60th percentile, and that's where we may end up offering a minimum value plan that just barely meets, maybe comes in at 62% instead of 90%, which would allow our member banks to offer a plan that is lower. It makes it easier for you all to basically check the compliance box and move forward.
I'm going to do one clarification to what Jay just said. Individuals are eligible to buy health coverage whether they get coverage from you or not. What changes is they're not entitled to a subsidy on the premium reduction or on their out-of-pockets. So when they go on the exchange, it's full cost for them. So to have somebody off of your plan go on the exchange, the only reason somebody in their right mind would do it, assuming that you're offering an affordable plan, meaning that it's affordable within the price range that you're required to comply with, is because their household income as a whole is low enough that they will qualify for the subsidy even though you're not penalized because you met your part of what you did at the individual level. Does that make sense? And our goal is to make sure that as an employer, the banks are not in a position to where they're subject to the penalties, regardless of whether the individual is rightfully entitled to a subsidy on the exchange or not. Okay, so as long as the employer offers the affordable coverage that meets minimum value, you've met your obligation. You're out of the penalty provision. The individual might still be able to qualify for the subsidies and the premium reductions because their actual household income is within the parameters that qualifies them for that. Affordability is measured based on single. It's the safe harbor is 9.5% of taxable compensation. Okay, not gross compensation, but when you're looking at the dollars, you're looking at box 1 on your W-2. It's after any pre-tax dollars for health care or any cafeteria plan or anything else that comes as a deduction that is not subject to federal income tax. So it's box 1 of the W-2 that you're looking for on that 9.5%. I wish I had a portal kind of like the one that Keith Smith showed you and go, oh, here's what the web looks like for the exchanges, but I don't know what it looks like. Things to watch out for. I think there's going to be a marketing blitz. I thought it really was going to hit in September. I'm really surprised that it hasn't hit. I do believe that it will start in October, and I think your employees are going to really need some help in understanding what it is that they're hearing, because The goal at this point is to get belly buttons into the exchange. The more belly buttons they can get on the exchange, the better the exchanges will fare. I mean, it's really a spreading of the risk. The more young, healthy individuals they can get on the exchange, the more they subsidize the cost of the older folks. So it is a push to get belly buttons on the plan. And I think you're going to see a lot of push from people that are going to be talking to your employees or getting information to your employees about how they qualify for a subsidy or they qualify for a premium reduction because their income level is within that 100 to 400% of the poverty level. And it's, you know, for most employers, you kind of get a sense where your individual employee is, but you don't always know what their household is. But that is where the push is going to come, and I think there's going to be a real blitz on trying to get people to sign up for the exchange. Oklahoma, you know, is not one of those states that has been very proactive in working on the exchange level. They're kind of like, okay, if you're going to do it, go do it. Insurance department has been very anti-PPACA. If you've seen the commentaries or some of the press releases that Mr. Doak puts out, you just kind of have to chuckle if you're confused like I am, because he's like, if you're going to do it, you're on your own. And I think that's kind of the way it's going to be here. It's kind of interesting how the country splits up, but basically Texas, Oklahoma, Arkansas is not. Arkansas has a different deal. Louisiana, they all have the same kind of deal. They're kind of Republican governors, and they're not playing. So I'm not sure how it's going to play, other than I do believe you will be seeing a large blitz come about to try to get people to enroll. When people enroll, they will enroll during October to December, and they will then come on board January 1. And like I said, I think there will be some surprises for people who find out that they really didn't qualify for the levels that they qualify because there is no mechanism to check. They're working on getting that system. It basically means allowing the IRS to transfer data to these exchange parties so they can verify the income. And there's some issues with that data transfer. Their systems are just not up and ready to go. The funding of PPACA, I don't see it being undone. I'm not sure that they can defund it enough. I think that there are so many pieces that are already built into it that they're just going to, they're rolling full steam ahead. The thing that I do want to remind you of, I didn't put it on here, is 2014 we will have the exchange reinsurance tax. That is not a tax that you guys will handle individually at an employer level. It's going to be on the trust, and it's the $5.25 a month per belly button that is going to be used to subsidize the exchanges because of the adverse selection that they're anticipating. So it's like $63 a year per belly button to HHS, and they're going to get to divvy it up however they choose to. Now, as bankers, I just got to share this part because I'm just kind of like, this can't be real. But here's how it's going to be billed. Tell me how much sense it makes to you. The employer of the plan will send HHS a notice to say, I have 100 belly buttons. The cost is $5.25 per month or $63 for the year. I have 100 belly buttons and they cost me $63. So I tell HHS I have 100 belly buttons. HHS will send us a bill. Say, okay, we've done the multiplication, you owe $663 or $630. When I get the bill, I then can pay it to them. And I asked them in Washington earlier this year, I said, if I know the number, I can multiply just as easily as you can. If it's $63 times 100, I can tell you how much I owe you. And the reason that HHS says they can't just take my money up front is because they can't take money because they have to create an invoice for it in order to be able to accept it into the system.
System limitation.
That's an example of how the systems work in this deal. They're not thought out, and they're not practical, and there's no cross-communication with them to make them really workable. So, I'm sitting here going, I still hope, optimistically, that they'll cancel this thing. I don't think it's going to happen. So I think we're going to be in for a real roller coaster ride in the next couple of months until people figure out what the exchange is and how it's going to work. Questions?
Assuming you're correct on
Yes. And I can tell you, a lot of people, there's two ways to keep people abreast. You can give them a bunch of information, say, here it is, read it, and you go figure out what your responsibilities are. When there's something that has to be done, we generally will make sure the plan complies with it in advance. So it's not something that you have to deal with. When you are required to give a notice, we will give it out to you and say, here it is. I'm the one that held that notice out because it just makes zero sense to me to issue a notice to people when you don't know what it is. So giving it out 2 months ago, to me, was like, are you kidding? I mean, that's insanity.
And we have sent out a few, and I just want a show of hands. I mean, we have addressed the pay or play delay and the exchange notices. And so I hope that everybody's getting kind of those bulletins. If there's any sort of an action point, please just, we're looking at that stuff just like you all are. Maria, she really sandbagged when she said she's a diligent researcher because that's what she does. And so she knows about it long before you ever hear about it on the news or you get your HR bulletin. But she also does a pretty good job of, if it's something that there is no actionable activity for you all to take, we're not going to tell you about it. You all have, and you all give us feedback. We feel like you all have enough to do with running a bank and Dodd-Frank, et cetera, that I don't know that it really does you all a lot of good. We actually were talking with a broker in Texas that is not real up to speed on the ACA, but he had gathered all sorts of information from all these different resources and HR websites and bulletins and everything, and he had an inch and a half thick packet that he was taking. This was a broker on a couple of our accounts in Texas, and he said, well, here's what I give to the banks. What do you all give to the banks? And we're like, well, did you explain any of that to them and tell them what applies to them or what doesn't apply to them or what's important or what? No. But I gave them this stuff. And I'm like, well, they get plenty of stuff. They're really looking for us to tell them, separate the wheat from the chaff and let's figure out exactly what do we need to concentrate on.
And as there will be some things that will come up, like, for example, the full-time employee determination is based on 30 hours. Our plans are written at 32 hours. And I'm trying to get a handle as to how many of you really actually have the 30-hour person as opposed to those that work 35 or more and those that work 28 or less, so that I can understand how we're going to do it. And that will be one of the areas that I know we will go back to you with and say, here's what we got. The waiting period is another one that will be changing. Some employers have a 90-day, and I can tell you I've already seen the list. We've flagged out who's got 90 days. If you're 60 days or less, it doesn't change anything for you. If you're at a 90-day waiting period, you will be required to make a change to a 60-day period come July 1. And we're working on getting those lists together so that we know who is going to be contacted about doing that. But rather than just send out a blast to everybody and inundate you with stuff that you then will choose not to read, I'm going to send you only the things that I hope you really do read. So when you get the memo like on the exchange, you go, oh, I haven't seen anything from her in a couple months. I'll read this one. There's just a lot of stuff coming out, and some of it filters out and changes from the time that it's first issued to the time that it really becomes applicable. Stuff changes, and you're sitting there going, good thing I didn't do it on time. So, but the plan will always stay compliant, I can tell you that. Yes, ma'am.
You mentioned the navigators. Can you tell us, because I've read a lot about be careful of scammers who claim they're navigators and they're not, and warning our customers about this as well as our employees who aren't on our insurance anyway. Can you tell us who those agencies are so we could let them know who the legitimate ones are? I haven't seen that.
I printed it out right before I came, thinking I wanted to have it in my hands. But that's not the one I printed. There's a Little Dixie community organization. Probably in my thing. There's 3 of them. I can certainly put that out for you, or if you give me a call, I'll tell you exactly who they are. Here's the hang up with that. Those entities are training individuals to be the facilitators or navigators. The entities themselves are not going to be the ones that are doing it all. They're training people to do it. I don't know what the process is to be trained and certified. And the reason for that is because they're not going through the insurance department. And, that's one of the pet peeves that the insurance departments have is these people are going to be out there providing information to help individuals, quote, enroll, but the insurance department has no jurisdiction over them, and they're not licensed insurance agents because the federal program doesn't require them to be licensed.
Yeah, they're especially not licensed insurance agents.
They're not licensed agents.
Because a licensed agent might know something.
Well, this is what I read, because as a consumer, you've got to be really careful that you're talking to somebody legitimate. And
Yep.
how do you know? And you're giving them all your personal information.
That's one of my problems.
That's part of what
There's so much
Commissioner
we don't
Doak's
know.
problem is.
Yeah, I don't know how it's going to work yet. I mean, if I think at some point when the web is up and the exchange web is open so that you can at least see what it is, I think you ought to be able to see a list of individuals or have something in there that keys information. Truthfully, I think individuals really can enroll on their own, that you don't have to have a navigator do it for you. If you go online and you do the web, the application form, you could fill it out on your own. I think we will get more information on that, and I'll try to keep an eye on anything that I can see, that I can think would be helpful to you guys to know that. I haven't seen it yet. I haven't seen who these people are. I know who is training these people, but I don't know what they are required to know. I don't know what they have to have as qualifications to get in the program. They're just 3 community organizations that are out there training.
What I'm reading is that the training is a sum total of 20 hours. 20 hours of training to people that are not even licensed agents.
Have you seen any requirements for what they have to do in advance to be able to be trained?
They have to attend or do some kind of webinar thing. It's very minimal.
Yeah, and they are talking about scams already. I think I would tell anybody that I don't think there's a reason that anybody has to enroll in October or November, to be honest with you. If the coverage isn't effective until January, I would sit it out and not do anything with it until I understood what the game looked like. I don't think we're going to know until they get it up and running. And that's one of my frustrations, is I can't put my hands on understanding what it is they're going to do or how it's going to work so that I can say, okay, here's the deal. Here's how it's structured. Or here's where you're going to go. Here are the people. I don't have any of that. And they are not releasing that information. I mean, you would think it's like a trade secret for the government, NSA can do better at finding it than I can right now. It's very frustrating. But I hear you. There is a lot of talk about scams already. I'd be very, very careful about giving anybody your Social Security date of birth. PIN numbers. Any other questions? I think the next time we meet, we might have some experience with exchanges, and I'll be able to tell you more. And if I see anything that I think is of value to you guys that would be helpful for you to have, I'll certainly make sure that you guys get it. Right now, it's just a frustrating experience.
Okay, we're a little bit over time, so we're going to wrap here. This is summary information. Success of our plan depends on us. We've already talked about this, but we would love extend that offer once again to all of our customers and all the owners of Advantage Health Plans. If you all need help communicating or training your employees to have more of a owner's mindset, we would love to meet with them, sit down in whatever is most convenient for you all. Number 3 there, create a Go for Green strategy plan with your employees. There's a lot of resources out on our website. We can also send it to you on some of the Go for Green initiatives. The last thing, and I'm going to sit down and let the trustees make any comments that they may want to make, and maybe they could tease you a little bit with the renewal information. But number 4 is something that we had discussed. The trustees had discussed it internally, and I wanted to toss it out and get some feedback between you all and the board and us, and that is, discuss making a pledge in your bank to protect your plan, and also make this pledge almost like a cultural norm for Advantage Health Plans bankers in Oklahoma and Texas and soon to be Louisiana. You know, you all have got a tremendous amount of plan assets that are socked away into this plan. A lot of those dollars have been earned by your efforts. And we still, and I'm not speaking to anybody here at this meeting, but there are still banks out there that do not look at the health plan the way you do. They simply look at Advantage as it was the cheapest column on the spreadsheet last year. And if we get a better deal next year, then we're going to go, whether or not they are a net contributor to the plan or if they really give the plan a bloody nose. And there has been discussion through the years, but it's really kind of gotten more steam with the board as things have really started turning really bright, and also in the face of the Affordable Care Act, that Advantage is going to be kind of a safe harbor, if you will, for some of the things that are going on out there. Is there any support about, like, if we were out to talk to a new bank in Texas, put together some sort of a agreement that, you know, you commit to stay with Advantage for a couple of years, and you commit to allow us to communicate with your employees about certain things, and if you're, you know, at least make a good faith attempt to utilize some of the go for green strategies and think like an owner. I don't know exactly how it would be written, but just as a concept, you know, you all have been, some of you all have been with this plan for 30 years. We are in a growth mode right now. We're getting licensed in Louisiana and getting ready to get, hopefully, knock on wood, get a endorsement by Louisiana Bankers Association. So we're talking about new community bank lives out there. And one of our struggles is instilling this culture into that new bank, because they're used to Blue Cross or Aetna or Cigna or United or Humana, and maybe have some sort of a acknowledgement that, hey, this thing is different, and you're not dealing with some giant insurance company's money. You're dealing with your fellow community bank's money. And anybody want to make any comments or either way on that?
I think bottom line is, you know, we can say we can get the most affordable health care, we can go see doctors, but, you know, the responsibility is going to be us as individuals. You can get as micro level as you want. If I want to leave this building, go get a 64-ounce big gulp drink or whatever, at some point in time, you know, the riskier you are personally, you know, it's going to flow through to the system. So I think we can instill that. I know the gentleman at the end's done a great job with his institution doing that.
Yeah.
Individual health care.
I think part of what I would like to see more of, and I think it's probably because I'm not asking the right questions, because Vicki comes to see us once a quarter and does an awesome job.
Right.
I mean, we're scaring us to death, or we're incentivizing us to do other things. She's very good at communicating. But, you know, it is very difficult to communicate to employees the importance of their saving, because, you know, even though in a small institution, you know, I've got employees, I guess probably the most, I think their whole thing is still, well, you know, really doesn't cost me anything because I'm going to make this choice. Right. And, you know, I can quantify, listen, guys, your premiums have gone up, and that's because you're the evil insurance company. So, you know, that's really our biggest challenge, is getting enough data to them to say, listen, if you make this choice, this is going to impact you, you know, in this amount. And right. So is it possible, I guess, to ask for numbers or runs that would help us communicate that to them? Because that's what employees take care about, is their bottom line. They, and I have employees that I think are very loyal and very grateful, but if it comes out of the bank's pocket, that's okay. If it comes out of my pocket, you know.
The funny thing is that they're not getting is that when it comes out of the bank pocket, it comes out of their pocket. Because they don't get that raise, they don't get that bonus.
And I'm thinking that if, you know, we have the ability to give them more specific data that would help them understand that. I mean, I can talk all I want to about it, but
we do. I think AB's got something he wants to say, but we do, as an administrator, we have some issues with privacy and HIPAA. So we have anything that we provide to a group it can never be able to be interpreted in such a way that it ties back to an individual claimant. So that limits that a lot. So a lot of it's aggregate type information that we try to provide for several banks of requesting, hey, can you kind of come out and give us an annual review for how we're doing? And the trustees are very mindful that we want that to always be framed in a manner that is in the context of Advantage health plans. In other words, how are you doing in comparison to other groups within the plan? I think your challenge is trying to get the employee to even care what is Advantage health plans and why do I care about any of this stuff. And I mean, I live that. We live that not just with even our bank plans, but our other employers that are non-banks. But we are making an impact. I know it's frustrating and everything else, but I'm just telling you, where we are as a group today versus where we were even 2 years ago, we're in a different place.
Can we ask for information that while it's not Susie had a hysterectomy, and it cost $50,000, are we able to ask for information that said we have hysterectomies in the bank? Can it be that specific? So at least the person who did that might be able to think, well, I was part of that.
That's a toughie. Yeah. If you've got 20 employees and you've had 5 hysterectomies, they all know who they are. And Vicky Toombs, which is a covered entity under HIPAA with criminal and civil penalties, just told us who they were. Even though we de-identified it, you see, there was a hysterectomy done on June 31st. I think Helen was out. It's Helen, and Vicky told me. That's our issue.
So you're
larger groups.
Talk to Vicky about what we can get.
I think what would be better is say, hey, you had a hysterectomy as an example, and it was a premier provider missed opportunity, and it cost the plan $22,000, and the employee, it cost them their out of pocket because it would have been whatever their out of pocket was versus zero. We can talk about things like that, but as far as putting any sort of a quantifiable, and we do have a few that are banks that are a couple of hundred employees. We can, I know it's not fair, but I mean, if they have had 3 hysterectomies, we can tell that bank about their 3 hysterectomies because they don't necessarily know because it's such a small percentage of their overall population. For the smaller groups, it's just almost anything we give you is, you all already know it, but the fact that I give it to you, now I'm in trouble.
We try to show those videos a lot to our employees.
Yeah.
I'm glad to see that you have some more out there. That's the way.
Allie Meyer, when she came back, and she's already filmed her follow-up to that piece, and she was in our office and brought the camera crew in and talked with me about it, and her angle, again, hadn't been released yet, and I hope it still sees the light of day. You never know, it could get derailed, but her angle was, if you saw her last video, it said, the critics say this transparency movement is only to those wealthy and healthy and able to pay. Well, she's aware that not all community banks are healthy or wealthy, but they have a health plan that is tying in to the transparency movement, and that's what her second follow-up story is about. And if she would, I've got her on speed dial, but I've only called her a couple of times because I fear if I call her too much and bug her, she'll just axe it. But I'm hoping that she'll come out with that because then that would be a huge teaching tool if she does it right. Maybe, did you have something you want to say?
One of the things one of the things that as a trustee, we have interesting perspectives. We are both. We have an obligation to the trust. We're also have an obligation to the bank, and we are also a user of the end product that we offer. So everybody up here is on the same health plan you are. And I'll just speak for my bank. Once upon a time, we had a plan that had a $100 deductible. And I think that, one time it was done away with. We thought the world was going to, earthquakes were going to happen. It didn't. And over the years, we have steadily increased our deductibles. The thing about increasing your deductibles on these plans is if you take into account everything else that we offer, this is one of the richest plans you can get. You can get free medication, you can get free lab work, free imaging, free surgeries.
Y'all get, I mean, there's a method to that madness, and I'll sit back down, but I mean, as deductibles go up, there are essentially loopholes that have been designed into those deductibles. And the loophole, I don't want to ever like anybody ever look at it as like an insurance gimmick. It's more of a, if you buy better, you get to go through the loophole. And because these guys' objective here is to keep the bank's costs as level as can and lower the employees out of pocket. But the only way you can do it is if they make that better decision. And that's where those loopholes come in. That's the design, though.
And that's where the consumerism part of this comes into account. You make, it only takes going to the pharmacy once and you get that drug that you could have got the generic for. You can still, we're still covering part of it. But you look at it differently and go, holy moly. The thing that clicked in my head was when I went to the emergency room and for poison ivy, and I had a $1,500 bill, and the Benadryl they gave me was, I don't know how much it was. It was like, it's crazy. But you have to be able to show your employees that you have a great product here, and that all you have to do is ask a question and look at what you can get, and it saves them, think of what it saves them out of pocket. The money, Dr. Smith says this several times. Think of all the money that, he saved these employees by us paying everything for them. And not only does it help the employee, it strengthens the trust. I hope that makes sense. Like I said, we thought the world was going to end when they did away with the $100 deductible plan. It didn't. Encourage your employees to take advantage of everything else that's offered, because it is a rich plan.
We are talking about unwinding a generation of conventional wisdom, though. It's no small feat. It really isn't. Guys, anything else? Anybody have anything to say, or anybody want to tease about renewal?
If I might just make one comment.
Please touch it.
We as trustees are not rocket scientists, and we obviously cannot take any credit for the progress that our plan has made over the last few years. The thanks goes to Jay and his forward thinking, and to Dr. Smith and his vision and transparency in healthcare. It's a trustee's responsibility to get us the biggest bang for our buck in healthcare, which we all know those costs are rising exponentially. But I think we all need to give Jay and his staff a big round of applause and credit for where our plan is today. And be thankful that the Kempton Company is the administrator of Advantage Health Plans.
Okay, well, we don't have any more questions. We're out of here. Oh, before Megan lets me out of here, no one would take next quarter. Things look very, very good from a renewal standpoint, though. Better than they have in a long, long, long time. Megan will not forgive me if I don't tell everybody to fill out your survey, which is in your packet. Thank y'all for your attendance.